Jeffries, lay member for patient and public involvement and deputy chair of the CCG. I'll be chairing the meeting today in the absence of our chair, Anoop Desai. Some housekeeping arrangements first, if I can. The meeting is not being broadcast live, but it is being recorded and will be available to watch on the CCG's website after the meeting. Members of the public have been able to join the meeting to watch this live. We'd be grateful if members of the public can turn off their microphone and camera during the meeting, please. There's an opportunity for members of the public watching the meeting live to ask questions about any items on the agenda or to ask for clarification if they're uncertain of anything that is discussed in the meeting. This can be done by raising your hand at the slot at the end of the meeting for questions, or raising your hand if questions are invited on any item by the chair. Members of the public can also raise questions by email during the meeting using the email box nwccg.communications@nhs.net. If the question relates to an agenda item, then this will be read out at the end of the meeting. The governing body will either answer the question or defer the answer, in which case a response will be prepared in writing within 7 days of the meeting, and the answer also set out on the CCG's website. And a reminder that the governing body meeting is a meeting of the CCG held in public, but not a public meeting. Accordingly, any questions not relating to the agenda items will be answered and displayed on the website, but would not be read out in the meeting. Finally, as the meeting is recorded and will be in the public domain, members of the public are asked to refrain from sharing any personal information and/or information relating to a third person when raising questions or requesting clarification regarding items on the agenda. Right, with all those housekeeping arrangements out of the way, let's turn to the agenda itself. The chair's introduction and report on any chair's action. You'll see in the paper there is a log of chair's actions as at today's date, 25th, or as at 25th of May, with one addition at the bottom there. The chair liaised and approved the first half of 2021-2022 financial plan. He did that after liaising with Hein van den Wildenberg, the Finance Committee Chair, after an email request from the Chief Finance Officer for approval. That's the only item of Chair's action that we need to note. So then moving on to apologies for absence, we have them from Dr. Anoop Desai, from Claire Hambling and Andrew Palmer. Are there any declarations of interest while we move on to item 3, please, in addition to those already recorded in the papers? Seeing none, let's move on to the minutes of the meeting held in public.
Robert Bennett has got his hand up, Chair.
Oh, Rob, sorry.
Yes, thank you, Chair. Just a reminder that a family member is a vaccinator in the National Vaccination Programme.
Thank you.
Thank you.
The minutes of the previous meeting, the public minutes of the meeting held on the Tuesday, the 30th of March, are in the pack. Does anyone have any points on the accuracy of the minutes, please? Doris.
Thanks, Mark. There's just a couple of minor typos on page 15 and page 20 of the pack.
Right.
The first one is under item 8, and it's towards it's just the 4th paragraph from the bottom. Instead of his, it should be this. And then there was a spelling on page 20 about respite.
Thank you very much, Doris. Subject to those corrections, are we happy to approve the minutes, please? Seeing lots of nods around the virtual table, thank you. On the action log, both items will be coming to the July meeting, so I don't think there's anything else to pick up on those. Karen, anything you wanted to say on any of them? Or either of them? No, thank you. That takes us to item 6 then, please. Melanie, the Chief Officer's update.
Thank you, Chair, and it's really good to see everybody again for our governing body meeting today. And thank you to members of the public who have joined to listen in. You're very welcome. I wanted to just pick out a few points from my report, and really just by way of starting off to give some context to which the NHS and the CCG is working. We remain under the most enormous pressure with the tasks. Our three top priorities we have, which are the elective recovery, the mental health for adults and children and young people, and the huge increase in the numbers of patients that, as we expected, are now presenting, coming forward for care and often in crisis. And then thirdly, the vaccination programme. So all of these three areas are significant, and I'm pleased that's why they're on the agenda today, to go into those in much more detail. And I wanted as well, again, just by way of context, to mention the enormous pressure that the GPs are under. Our GP practices across Norfolk and Waveney have worked in just the most outstanding way since the beginning of the pandemic, changed so much about the way they're operating in primary care networks, and the majority are now heavily involved still in the vaccination programme. But I wanted to just thank our GP practices in particular for the enormous effort they're making, and how hard they're working. It's hugely valued and appreciated. I wanted to also just mention, just moving on, how delighted I am to welcome Emma Ratzer, who's the Voluntary and Community Sector Assembly Chair for Norfolk and Waveney. It's taken quite a while for us to develop an assembly for the voluntary sector, and we appointed an independent chair just recently, Emma, who substantively works as a chief executive in the Norfolk and Waveney area and runs the Access Community Trust, a really very special charity doing lots of important work with many of our really vulnerable people. So I'm so pleased about the appointment, because I think it will enable us to work in a more effective way, to engage more systematically with the voluntary sector and make it much more mainstream in everything that we're doing, which I think has been more of a piecemeal approach up until now. So that's very, very positive. And then I won't mention the vaccination area, because we've got a special report on that, but I did just want to call out and focus on the anti-racism strategy for the East of England for the NHS, that I'm so pleased the CCG and every organisation in the whole of Norfolk and Waveney has signed up to the anti-racism strategy. And what a day to be mentioning this here today, a year after the anniversary of George Floyd's, when he was killed tragically last year. So it's really important that we focus on this, we continue to. And I've been thinking about what the CCG has done over the last year to just try and improve the understanding about racism and race and inclusiveness and diversity. And there's clearly always so much more we want to do, but I do think that the organisation has shifted, and the NHS has shifted as well in terms of its focus. And we have a very important role as a CCG on our leadership development and ensuring that the way we're working is in the most diverse and inclusive way around race and racism. So I'm very pleased that we have signed up to the anti-racism strategy. And then lastly, I wanted to, again on this same train, just to mention, like many NHS organisations, we're now encouraging our staff to adopt personal pronouns at the end of their email signature and in correspondence. And again, this is, I think, really important, particularly for the transgender community, but people who are from the cisgender community will also be including personal pronouns. And I'm so pleased to see many people from the CCG include their own personal pronouns at the end of their email signature, in terms of which is important in our equality and diversity strategy. So I'll stop there, Chair, and happy to take any questions.
Thank you very much, Melanie. Are there any questions, please, on the Chief Officer's update? I see one. Karen, just guide me as to who that is, can you?
I think a member of the public, Joe Rust, has put her hand up, Chair.
Right. Joe, does the question relate to what you've just heard?
Absolutely, yeah. Well, to the Chief Officer's report that she's just outlined. So certainly, yes.
Okay.
May I go ahead?
Yeah, go ahead, and we'll decide whether to deal with the answer at the end.
Okay, thank you very much. First, I would like to commend you on the work that you've done around anti-racism and the personal pronouns. As you've pointed out, it is a year after George Floyd's death, so I'm sure many that have supported Black Lives Matter event and anti-racism events are very touched and appreciate the fact that this has been mentioned today. So thank you very much. As one of the founding organisers of Pride in Kings Lynn, I'm also really pleased to see your support of the use of personal pronouns. But going on to the main body of your report, you have said that the recovery of elective care will remain a significant challenge for some time. And I would ask the question as what impact the closure of critical care unit in the Queen Elizabeth Hospital because of the rack planks and the need to put acro props up had on the Queen Elizabeth's progress towards elective care, because as we all know, the critical care patients had to be decanted into theatres, which obviously meant theatres were then closed for elective surgery. So if you could give me an update on that, that would be much appreciated. Thank you.
Joe, we've got, you'll have seen, we've got on the agenda at item 9, elective recovery. So can I suggest that we defer a specific answer to that question to the end of the meeting, to the extent it hasn't been dealt with under item 9?
Yes, happy for that. Thank you.
Is that okay with you, Melanie?
Yeah, I think that's a good suggestion. We can take all the questions at the end, and maybe Mark might want to pick it up in his report when he gives it as well. We can then come back to Joe's question again.
Thank you for the asking the question, Joe. Are there any other questions, please? Georgia Gabrielson. No. Okay, that's fine. Thank you. Let's move on to the vaccination programme, please. Item 7. This is being led by Howard Martin, Locality Director for West Norfolk, and Tracy Williams, who's one of our 4 elected healthcare professionals. Howard and Tracy, can I hand over to you, please?
Yes, thank you, Chair. We'll do a bit of a double act. I'll just summarise, I guess, where we are with the vaccine inequalities programme, and I know Tracy wants to talk about the work that's ongoing around health inclusion. I think it's worth just starting off by saying or re-emphasising what Melanie just said as part of her Chief Officer's report around what has been a fantastic vaccination programme. And this presentation really needs to be seen in that context, because what we're talking about here is the work that's we're trying to do to engage with very hard to reach groups. But actually the overall uptake is really tremendous, and it's really important as a bit of context. And also this presentation doesn't really cover all the aspects of that work, so it's just picking up on some of those things as a bit of an example. So I think I'll just start off by saying a little bit about what the Vaccine Inequalities Oversight Group is. So this was set up a couple of months ago to better understand where our vaccine inequalities are as a whole system. So how we're using data in a bit of a smarter way, and therefore also to better connect programs of work to those areas of inequality and really share best practice between the various work streams that are happening, so that everyone can share with some of that work, and then also to support specific interventions where they're needed. And a really good example of that is how we've very quickly got the vaccine bus off the ground and in fact are now progressing with the commissioning of our second bus. The members of the Vaccine Inequalities Oversight Group are comprised of CCG Trust, Norfolk County Council, Suffolk County Council, Borough Council representations, and also voluntary sector. So what does the data tell us about vaccine inequalities? Well, there's a very strong correlation between deprivation and vaccine uptake. There's overall a gap of about 10% between the most deprived and the least deprived deciles. So 85% roughly versus 96% as of that sort of mid-May period. Those numbers have crept up by a couple of percentage points since then. And that gap has been reducing over the last month, albeit very slowly. We're talking about 1 or 2 percentage points between the most and least deprived. We know that there is an issue with hesitancy within our white other ethnic population, and this appears to be largely within the Eastern European populations. And we also know that the particular areas of geographical note are Yarmouth Parade, Kings Lynn, North and South, Norwich City Centre, and Thetford North. The current trend seems to be showing a bit of an improvement in Thetford, but we're still checking through the data on that. And then just to highlight some of the key system-wide actions that have been taking place. So the first thing I think to note is that in Norfolk and Waveney, we've really, I think, been at the forefront really of sharing data between the CCG and the local authorities in trying to identify people, particularly in those cohorts 2 and 6. So there we're talking about unpaid carers, for example, and also health and social care workers. So these are people who may not be known to health services necessarily. And likewise, the county councils may not have had contact details. So by marrying up the data from primary care to secondary care, we've actually been able to pass on about 20,000 records onto vaccine sites to get people booked in. We've also been doing some proactive calling through our PHM approach via Protect Now, and that's been expanded to include the use of translators and also some foreign language speakers from some practices. And I think worth mentioning the exercise that happened in Yarmouth Parade about 2 or 3 weeks ago, which was a brilliant example actually of real collaboration between primary care networks, the borough councils, voluntary sector, in conjunction with pop-up clinics and also the vaccine bus appearing for 3 days to really get people out within that hard-to-reach cohort to get them vaccinated. And there is a very similar exercise now being planned in north of Kings Lynn as a result of that exercise. So there's some really good learning there, and that project is commencing from the 7th of June. And you'll also have noted that we have commissioned a vaccine bus with the second one due by middle of June. The current bus has visited about 7 sites, including most recently a pop-up in Norwich City Centre. Its main focus is on priority factory sites as identified by public health, and as well as doing targeted town centre pop-ups as I've described in Yarmouth and Kings Lynn. And the team are also now looking at how we can expand the capacity of the bus to maximise the number of vaccines that can be done, and also how we make all the contacts count. So when people are being vaccinated, are there other things that we might also be wanting to consider as part of using the bus, including screening services, smoking cessation, etc. So there's lots of other possibilities that these buses may lend themselves to in future. If I just hand over now to Tracy, if that's okay, Tracy, just to talk through the health inclusion groups.
Absolutely. Thank you, Howard. So yes, I really want to focus on some of the work that we've been undertaking across the system in respect of our health inclusion groups. So specifically, if you don't know who those groups include, I'll just make you aware of that. So it's our homeless and those that are in any temporary accommodation, which might include bed and breakfast accommodation, hotel accommodation or group homes. It's our Gypsy, Roma and Traveller community, our sex workers, vulnerable migrants, those that are entering or leaving the criminal justice system, including offenders and those in probation services, those with addiction, substance misuse problems and those houses of multiple occupancy as well. And also I looked after unaccompanied children and young people. So we do know that these particular groups often have very complex, chaotic lifestyles and may not always see that the COVID vaccination is a priority for them. So our approach has been to form a particular programme of work, working very much with our voluntary community sector organisations that we know will be trusted by community groups, and also working with our 8 district councils around the system and linking very closely with our primary care networks for the operational delivery of a vaccination roving model or a pop-up or whatever might be appropriate for the group. So just a flavour of some of the activities that have been taking place across the system. So for instance, in Norwich, we've had a roving vaccination model that's provided pop-ups to a number of hostel settings across the Norwich locality. We've had 2 pop-up sessions that has supported the vaccination of our asylum seeker community in Norwich, and that achieved 55 vaccinations over 2 days. We've had a pop-up in one of the mosques during Ramadan, which started at midnight and finished at 2:30. We managed to vaccinate nearly 100 people. And there's actually a pop-up mosque vaccination clinic happening at this very moment in time, overseen by the Norwich PCN. And we've had very flexible appointments, so allowing people to have that flexibility at a PCN clinic to go at a time that's more suitable then, but knowing that they're going on a day, but having the flexibility to go in. In North Norfolk, we've supported the homeless communities to access the vaccine clinics in the very same way, having flexible appointments and also doing pop-ups in hostels. In South Norfolk and Breckland, we've had very close working between the district councils, and we are planning a pop-up clinic soon in the Salvation Army premises in Thetford, and we're having a similar approach in Durham as well. In the Great Yarmouth and Waveney locality, one of our practices, East Norfolk Medical Practice, have done lots of pop-ups in various hostel settings, and also focusing on the utilisation of the Protect Now calls to encourage people to access their vaccine. And as Howard has said, we have the bus that parked up on Marine Parade and very much use the community champions that Great Yarmouth have to kind of support and encouraging people to attend to their vaccine. And we do know that in that particular locality, there are a lot of houses of multiple occupancy where we do feel there may be some of our migrant workforce that we encourage to attend their vaccination appointment. Similarly, in Kings Lynn, focusing on calling people and understanding maybe why they haven't had the vaccine, how can we support that, how we can help them have an appointment, and there's some more roving clinics planned there in the next few weeks. So across the Norfolk roving system, a lot of the work in respect of our Gypsy Roma Traveller communities has been very much working with the Gypsy Roma Traveller team that are based in the County Council. And again, lots of communication, engagement work, working with our communications team to ensure the materials we're producing very much support, the queries that people have and answers questions that they have. And we have a particular campaign running at the moment, which is called #IHaveHadMine vaccination, which is proving very popular. We have shared some sort of numbers of vaccinations that we've achieved in our inclusion health groups, which is part of the pack, but I've got some up-to-date figures. So really, for our homeless population, we have a denominator total of 1,199 people that we hope to vaccinate, and so far we've vaccinated 555. As another example, in our Gypsy Roma and Traveller population, we have a denominator of 257, and already we've vaccinated 150. So we're doing really well. Asylum seekers, we have a denominator of 98 and we vaccinate 80 people so far. So lots of collaborative working to really support the access of vaccination for some of our most underserved communities. Happy to take any questions.
Howard and Tracy, thank you very much indeed for that. That was really helpful. I'm sure I speak for everyone and I say if we'd been told a year ago that we would be in this position of having achieved such vaccinations, we simply wouldn't have believed it, and it's a remarkable achievement, and particularly on the inclusion side as well. Governing body members, any questions, please?
There are a few questions there. Mark, you've got Rob, Kathy and Doris.
Yeah, thank you. Rob, should we kick off with you, please?
Okay, thank you, Chair. It's a comment really, and it's a big congratulations to Tracy and Howard and their team for all of the hard work and the organisation that's gone into getting us to this position, and clearly that's all very good to hear. Thank you.
Thanks, Rob. Kathy?
Thank you. I guess I'd my congratulations to those of Rob, really. I thought it was really helpful to the way you presented the data in terms of deprivation and ethnicity. And I thought it really paints a good picture, but it also shows how much hard work is being put in to reach these hard to reach groups. I guess my question is are we targeting those groups based on age, or is it now that the program is actually the general program is going to be vaccinating younger people? Is it likely that more people will come through? The thought in my mind is that a lot of the people, Eastern European community, come here to work, so are in the younger cohort. So is it likely we'll pick more of those up as we go through?
I'm happy to answer that. I think we're hoping that we will. Actually, a lot of our roving visits to the factory settings has been targeted at our Eastern European community migrant workforce. And actually, we're learning now that they are, as the cohorts are called in, accessing their vaccines as well. So we kind of all the time are revisiting, where do we need to go? Where are we potentially leaving people behind? Where is the uptake slowest? So we're really looking at the data, and crucially from public health, we absolutely look at the data and see where we need to kind of rove our model, put our pop-ups, park our bus type of thing. So, but yeah, we are seeing the uptake increase, and it might be slow, but we know where we need to target, and that's what we're focusing on.
Fantastic, thank you.
If I could just add, I think it's really important not to understate the challenge, though. This is really hard work. And you can see there's lots of programs getting, what look on the face of it this numbers, but it's the accumulation of all those efforts that makes a difference. Just to answer your question on the data, Kathy, so that this particular program presentation focused on the over 50s. What we do know now is that the issues around hesitancy seem to be increasing as we go down the younger group. So I don't think this problem's going anyway anytime soon, unfortunately.
Doris.
Thank you very much. It's really good to see the data and your targeting approach. So thank you for the report and the updates as well, and the work of the team. I just have a couple of questions. One was in relation to the population health. From my memory, not all practices use the Eclipse system, and I might have remembered wrong. If that's the case, what happens to the data? How are we going to include practice that are not on Eclipse on the population health management? And the other one was in relation to the hard to reach group, because the prison and probation service, that's included, but I've not heard anything in terms of what's being done in the system, given that we've got a number of prisons within Norfolk and Waveney. Thank you.
Do any members of the governing body have other questions?
Should I do the criminal justice question first, and Howard, you can answer the Eclipse question? Okay, so yes, we do know that currently that we have 3 prisons within the Norfolk and Waveney system, and we do know currently they are vaccinating according to cohorts, so with the JCVI guidance. But I think certainly they do use discretion on with that vaccination as well. So very much, we actually had a meeting this week in respect of prisoners on release, and we're looking at what's called a discharge kind of suite, and how we can encourage vaccination before people go back into the community setting, and also if they haven't had a vaccination, how we can support that. So there's some work going on, but you're right, that's an area that we do need to put some focus on, but vaccinations are taking place in the local prisons currently.
Just on the data issue, I guess all I would say at this point is that we're closely working with those practices to see how we can facilitate better sharing of data, I think. But obviously, logically, it makes sense to do it through one central point, I guess, is the ultimate aim. But we'll see where we get to.
Thank you.
Are there any other questions from governing body members? Joe Russ, you have your hand up. Can I just take a note of your question so we decide whether to answer it now or at the end of the meeting?
Yes, of course. It's concerning the times that the pop-up bus is going around. Obviously, I see that you have attended the actual workplaces. Many of our European friends do work in the food factories, but also many of them will work a variety of different shifts. So it's just questions when we're looking at inclusivity and getting out there out of hours. Are the pop-up buses attending outside normal office hours to enable those that work a variety of different shifts to access it, because we do know that many are not being let out of work if the pop-up bus has not gone to their workplace.
Thanks for the question. Tracy and Howard, are you able to answer that now, or would you prefer to answer it at the end of the meeting?
I can answer that now if you like, Chair.
Okay, Howard, yes, thank you.
Yeah, so I think at the moment the bus is working in hours. We obviously need to work out how we can, where it's needed, if it can work out of hours. Just thinking about things like the King's Lynn exercise from the 7th of June. So we're also working in conjunction with the primary care network there, and they will be providing pop-ups or walk-ins out of hours, so from 5 till 8 in that instance over 3 days that week. So we're trying to do a bit of a combined model here, working obviously within the constraints that we have.
Thank you very much, Howard. Thank you. If there are no more questions, let's move on to item 8 then, please, on mental health, can we? An item to discuss the work of the CCG with regard to mental health services commissioning. It's being led by Dr. Ardin Ross, one of our other 4 elected healthcare professionals, and our chief nurse, Kath Byford. So over to Ardin and Kath, please.
Thank you so much, Chair. I'm going to start, and then Ardin will join in the presentation. So I've already been mentioned that we know we've seen increases in the incidence, but also the acuity of people experiencing mental health and wellbeing challenges during the pandemic. This is a national issue, but obviously it's of real importance for us in terms of our Norfolk and Waveney population. Although I would say as well that the pandemic has brought some strengths and positive consequences to our system, one of which is building with much even greater pace and acceleration of the strong transformation programme that was already in place for children, young people and adults mental health and wellbeing services. And it's really brought the system, the wider system together in order to work collaboratively to continue on our improvement journey in this area. I'm going to talk to the children and young people's mental health side of things. I'm certainly not going to read through the paper, just going to pick out some key points, if that's okay, before handing over to Ardin. So section 1.1 of the paper gives a background to the issues of children and young people's mental health, but what I wanted to point out was the section that relate to the impacts, what impacts on mental health of our children and young people in our population. And many of that relates to societal challenges such as family income, concerns about the ability for their parents to be able to pay the bills, also issues to do with bullying, academic achievement, sexuality. Also poor parental, both physical and mental health, deprivation, abuse and neglect. So are all key factors in what has an impact, an adverse impact on mental health and wellbeing for children and young people. We have also seen increased, both nationally and locally, increased presentations of children and young people with eating disorders or disordered eating. And again, that level, not just the numbers of children and young people, but the level of acuity that they are presenting with. Section 1.3 of the paper, I wanted to point out some of the services and changes that have been put in place over the last year. Again, part of that enhancing of the improvement programme across the system as a positive outcome of the pandemic. So we know that we had and have still a historic waiting list with regard to children and young people's mental health. But what has been put in place, which I'm really delighted at, is that we've already reduced the waiting list by 1/3 since January. for those services provided by NSFT and VCSE partners. And that's really, really positive, because what we're also seeing is not just numbers of children on the waiting list, but it's also because children are receiving treatment much faster, and there's also a completion of access to the services, not to discharge children from services, but actually to enable them to leave the services but re-access if they feel that they need it. And so that's a positive example of what's working well. Another thing I'd like to point out is the expansion of the RUSH project. And that's a collaboration between the Mental Health Trust and MAP, which is the VCSE colleague, system colleague. And essentially, this is a service for children who have been self-harming. So there has been a big increase in our system of children self-harming and presenting to the acute hospital through the emergency department. And a pilot was put in place in partnership with the Norfolk and Norwich University Hospital. And it was so successful that we've now rolled out that funding substantively for all 3 hospitals in Norfolk and Waveney. And in essence, what happens if a child presents self-harming to the hospital is that they get a response within 3 days, and then some targeted work to support them around their self-harming behaviours, with a view of aiming to reduce those repeating behaviours and reducing the likelihood of them going back into hospital as a result of that. And the impact of that service has been really positive, hence the rollout across the 3 hospitals. The extension and expansion of the Couth digital offer. So this is a digital platform which is a way of managing demand from children and young people in a very different way. And it's being promoted through schools, GPs, but also on platforms such as social media in areas essentially that will be able to target children and young people who would benefit from the service. The impact of Couth has helped in reducing demand for other services, but it's also very focused on encouraging self-care, and there is evidence of peer-to-peer recommendations. So it means that children and young people are referring or recommending that service to their friends and family. But one of the real benefits of the Couth service is that a children or young person can use the service anonymously. So that helps prevent the fear of children being labelled if they access a mental health service, so that they can get the help that they need without the fear of of what that might mean for them in the future. And then the last point I wanted to raise is with regard to the way in which we're working with our system partners, particularly Norfolk County Council. There is a real need to focus on the early intervention and prevention. It's recognised that children and young people may present with a mental health wellbeing issue or anxiety, but we need to move away from this automatic approach to a medical model of care, and it being about early intervention, holistic family support, child-based support, so that we can make sure that that child or young person is able to stay at home, supported by what they need to do so, as opposed to escalating the level of care to be very medicalised. So that's just some examples of the work that's been put in place and through our accelerated transformation programme for children and young people. And I'm now going to hand over to Dr. Arden Ross, who's going to talk about adult mental health services.
Thank you, Kath. I think it's fair to say that in adult mental health, the presentations, just like in children, have also massively increased, both in severity and in wide-ranging need over the last 18 months. In particular, we've noticed that people are presenting with increased severity of pre-existing mental health conditions, but also we're seeing new presentations in people who've never experienced problems with their mental health before. And some of the key areas where we're really noticing that acuity of presentation is in eating disorders, in self-harm and in psychosis. As a consequence of the pandemic, the transformation plan that was already underway was massively accelerated, linking in with systems partners really effectively, so that business continuity systems were triggered in order to stand up services such as the first response service within weeks of the pandemic starting. This was an example of organisations coming together to provide that 24-hour all-age response to people experiencing significant mental distress, but also providing support for professionals as well who are looking after those people. That collaboration has continued throughout the pandemic, linking in with both with VCSE organisations and with county council colleagues. And in addition to that, really bringing in people with lived experience as well to really drive forward and determine the nature of the work that we've been doing. As a consequence of that, NHS England recognised our bid for community transformation money, and we were successful in securing £13 million of investment for our system based on the plans that we'd put in place together with our partners. And that allows us to start a 3-year programme of very exciting developments, focusing on those people in our communities with severe mental illness, particularly personality disorders, those people who are in need of mental health rehabilitation, and those experiencing eating disorders. It also enables us to work with systems partners to really drill down and address some of the inequalities in our system for those accessing health and care, and some of our underserved populations. The eating disorder presentations have really accelerated in severity over the last year. We're noticing more that there are huge numbers of people coming forward with very complex presentations, very severe, and as a consequence of that, we have accelerated our response so that we have integrated FREED, which is an early response model, across our system. This enables us to support people at a much earlier stage of their eating disorder before behaviours become entrenched, and thereby, in addition to supporting their families, to tackle the issues at an earlier stage, preventing increasing severity. It's also enabled us to expand our community eating disorder teams, and our ambition is to increase those by 50% by the end of this year, and we're well on track to do that. We've also been recognised as an accelerator site by NHS England, and they have invested in an intensive community support model. We've had a meeting just last week, as this is a relatively new investment, to bring together all across the system, including VCSE partners, a rapid response team to both allow people to step down from inpatient admission, but also to prevent some of those admissions as well. In terms of our primary care mental health response, our plans were already well underway before the pandemic to recruit mental health teams into our primary care networks. And I'm now really pleased to say that we have fully recruited all of our mental health practitioners across the PCN sites. And by the end of the year, we will, using a framework approach, we're hoping to have our recovery workers also in place to support primary care mental health teams, who will be a first response function for those people accessing primary care with mental health distress. Through that model, we're establishing links with our local psychiatrists, initially starting with some pilot sites to develop advice and guidance, but hopefully building on that so that across Norfolk and Waveney, GP and other primary care clinicians will have access to advice and guidance from our psychiatric colleagues. We've also been working closely with a crisis stakeholders to provide a crisis response and home treatment team, providing alternative crisis services in the community. And there's some examples of that detailed in the paper, one of which is Holly Tree House, which is a support service that opened in February 21 for 4 short stay beds for people experiencing crisis to avoid them having to go into acute hospitals. We have plans to open 2 further crisis houses during 2022. We've also got our wellbeing hubs, which also provide a dual functionality of being places where people can go to with mental health crisis, supporting them until midnight in the evenings. The Rest Crisis Hub opening in Norwich later in the year, and in just a month's time, the one in the East opening, and subsequent to that, a crisis house in the West. And the providers of those are Mind and Access Community Trust. I'll talk about those in a little bit more detail later. Mental health referrals have increased during the pandemic, so we're working very closely with our colleagues around early intervention in psychosis, and there have been some targeted working using Evolve to support those people, again with a view to avoiding hospital admissions. We've also progressed our plans to open some beds in Blickling ward, opening with 20 beds from June, and the reopening of Rollesby ward, providing an additional 10 beds in August to prevent out of area placements. And we're very excited about some work that we're beginning with Norfolk County Council with an £18 million investment to provide supported housing for those people with significant mental illness, to provide a holistic wraparound response to avoid admissions and to prevent, in particular, out of area placements around a supported housing project. Dementia is also an area of increased focus for us. With our increasing investment, will allow us to provide that peri-diagnostic support, linking in with VCSE partners to support those people at the point of being referred for diagnosis of their dementia, but also to provide ongoing support through that journey. We're also wanting to target medication usage and an increased awareness of dementia, embedding dementia awareness and diagnosis throughout our system. We've invested in well-being as well, which includes additional, in addition to what was already provided, special targeted support for people with long-term conditions, and also very much focusing on trauma-based care as well, so that well-being is really raising its profile, and we'll be linking in with well-being practitioners, individual well-being practitioners, to our new primary care mental health teams. And finally, the hubs, as I said, are going to be if not already open, which two of them are digitally, increasing that face-to-face offer throughout the course of 2021 as a drop-in facility around that a cafe model and a social enterprise-based community model, providing additional therapeutic support. Those hubs have already started to link in with crisis response teams and the liaison teams at the Acute Trust. So I'll hand over to Kath around the communications piece.
Thank you. Again, the paper sets out some of the activities that have been in place over the last few months with regard to engagement. There was just one thing I wanted to point out that is in addition to what has been included in the paper. Last week, a number of colleagues, including Dr. Arden Ross, visited East Coast Sixth Form College specifically to talk about mental health and well-being for the people in school, promoting what they can do to improve their own mental health and well-being and those around them, or how to ask for help and support if it's needed. So this is a really important programme in terms of the comms engagement, how we reach out to our population in very different ways, in ways in which that's accessible to the population, and we will continue to make sure that this is an area of real priority for us. I just wanted to finish, if that's okay, to say that we've heard some really positive information about what's been progressed throughout our system with regard to mental health and well-being. But what I will say is this is an improvement journey, and we know that there is still much to do for our population, and I would like to reinforce the fact that we very much know that we will continue to aspire to improve services for our population and to provide excellent level of care, both at the point of delivery, but also making sure that that care is as accessible as possible. So thank you to governing body, but particularly thank you as well to our system partners, colleagues, frontline staff, and staff working on the improvement programme. because what we've been able to describe today is as a result of all of that amazing hard work that that they're delivering. So thank you, Chair, and I'll hand back.
Thank you, Kath, and thank you, Arden, very much. Can I open up the discussion to questions from governing body members? Hein, first, please.
Thank you, Chair. It's really a comment. I want to commend Arden and Kath on a fantastic note, a really good update on everything that's happening, and sort of echo what Kath was saying. I think also the note portrays that it is indeed a journey, but I think you should take some pride of all the green shoots that are coming through. I was particularly pleased with the focus in the children and young people around early intervention and moving away from medication by default. Let me leave it at that, Chair.
Thank you, Hein. Tracy, then Kathy.
Yes, thank you. I mean, thank you. It's such a good to have that update, sort of all encompassing, all age, and all of the great work that's happening in the system at the moment. So thank you for that. My question is a little bit in respect of the wellbeing hubs. Just really interested to know what the digital offer provision is at the moment and how accessible that is, thinking about some of those groups that might in fact be digitally excluded, and kind of what approaches we're taking for those that can't access that digital kind of opportunity, and what do we have in place, and what will we have in place in that respect?
Thank you. Arden, would you be able to answer that question?
Yeah, so the digital platforms are being used as Attend Anywhere, but you're right, Tracy, there's a really long way to go around the reaching out to those underserved communities. I think the main thrust of the work will be once the hubs are actually open for face-to-face contact, actually, and that we can really promote that widely. And it's very exciting that it's only a few weeks to go until that starts to happen.
Kathy, then Rob.
Yes, thank you. Echo Hein's comments. It's really encouraging to see all the work that's being done, and particularly around children and young people, where it's been an area of huge concern for some time. I just wonder about impact measures, and I'm thinking that this is an area of huge risk, so we may have an update in the next few months, and I could almost see a sort of there's obviously some kind of performance suite behind here, and I think it'd be really helpful to, in due course, just see what impact on the population these excellent pieces of work are having, please.
Yeah, thank you. We will definitely pick up on that. I think it'll be a combination of recognising demand profiling changes, but also impact and outcomes. So I'd be keen to avoid KPIs and be much more focused on the outcomes for children, young people and adults in terms of the services that they're able to access, the timeliness, and how they feel as a result of the access to those services. So I completely agree, Kathy. Thank you. I'll take that comment back.
I think it'd be also worth drawing attention. We're going to be using a tool called Dialogue Plus, which is an evidence-based quality assessment tool that people would carry around with them, which is very much around a coaching approach to noticing improvements in their well-being, and people will be able to map that for themselves, but also to carry that with them if as they reach services.
Thank you.
Rob.
Okay, thank you, Chair, and thank you to Kath and to Arden for a very comprehensive and clear report. There's a lot clearly that's going on, and it's clear to me why this is one of our key priority areas, as Melanie highlighted at the beginning of the meeting. I had two questions. Firstly, about staffing, because some of the areas that we're doing work in and we've got work planned for the future will require staff with very specialist skills and very specialist experience. And I just wonder whether those staff are out there and available, and how confident are we about being able to recruit where we need to. And then secondly, I was very pleased to hear Arden's comments about the link between NSFT and primary care and the appointment of mental health practitioners working alongside GPs. Would you like to say a little bit more about our experience of how that's been working so far? Thank you.
So should I pick that up, Kath? So we're starting with the mental health practitioners. It's early days. A lot of them have just taken up their posts in April. So we've set up a number of mechanisms for them to not only interact and engage with each other, to learn from each other, but also we have a network of GP mental health champions across Norfolk and Waveney who regularly meet, and we have webinars, and we're linking those in with the mental health practitioners as well, to support them, but also to help embed them in primary care and primary care systems. So I'm hoping that will be an ongoing piece of work in addition to a continuing steering group that we have around that piece of work. In terms of the workforce, we're linking in very closely with colleagues in workforce who are also part of all of our groups, and part of the community transformation money we've already used to provide training for new associate psychology positions from the UEA, who will be starting this autumn, and will be then coming into all of our mental health services, providing additional psychological support, but aware that we need to be very creative about attracting and retaining staff to all our mental health services.
Yep, thanks, Arden. That's really helpful. Thank you.
Melanie.
I really just wanted to amplify that point that Arden's made about workforce. And we'll never have enough psychiatrists, psychologists, nurses, therapists in the NHS. There will never be enough. And there are some roles, many roles, and that only they can do. But I am really excited by some of the innovation that I'm seeing now around, Arden just mentioned, all of the psychology graduates that, it's a very popular degree now, but if people are not doing a clinical psychology course, it's quite a hard market. And so I'm really pleased that we've now got quite a bespoke offer in Norfolk for graduates, which is one. And I also just wanted again to just highlight, this is where I think we've been pursuing a far too traditional model for so long across Norfolk and Waveney. And I'm pleased that with the transformation and creativity and the move from a more medicalised model, this is an opportunity to involve the voluntary sector more. They have a big workforce. It's often looking after some of the most challenged communities and people within Norfolk and Waveney. So I think there are lots of different ways we can look to look after people with a different workforce.
Are there any other questions or comments from members of the governing body? Can I just go to Richard Chilvers then, a member of the public who's got his hand up, and just to see what your question is, Richard, and whether or not we answer it now or at the end of the meeting?
Can you hear me?
Yes, we can. Thank you.
Yeah. I think, to be honest, this is a great improvement in the sense that very much more, rather than top down, far more dissented way of organising. But I just wanted to notice the community hubs are quite. There's only a few at the moment, and obviously it's early days. And how they relate to the PCNs, where you've got the medical practitioners in the 25 PCNs. And the linkings which with the PCNs with the schools, really, because I think it's very important in terms of the centering on children and how is the new medical practitioner going to tie in with the schools in each PCN area. And I know it's early days, but there are resources available, and I think that many people who are mentally ill, in fact, find it very difficult to maybe go into some of these centres, even if they are very walk-in and are open most hours, so that in fact a one-to-one, which was tied in with the schools and with the PCNs. So I say I'm asking a question now because I may have to leave a bit later when it really comes to members of the public. But I think it's a very good. I think it's certainly a great development. I do have personal issues related to my children who do actually access Norfolk and Suffolk Foundation Trust. So thank you very much.
Thank you.
Chair, shall I pick up the issue about children?
Yes, do, unless you prefer to do it at the end of the meeting. Whichever's easier.
Absolutely. So I think Richard is absolutely right. Services for children who are attending school or other educational settings need to be able to access services in a way that meets their needs and abilities. So aside from the digital platforms that I've already discussed, where children and young people can access support digitally, which will suit a big proportion of that age range. Another really important approach and improvement that we've made is about having education-based mental health support teams in place. So we've already got 2 of these teams in place across Norfolk and Waveney. 2 more are starting sometime in this year, and then 6 further teams to start in 2023. So again, not suggesting that everything is in place, but we recognise what is needed and are putting education-based accessible support for children in schools to be able to access those services, and if necessary, be referred on to other areas of support should that be required.
Thank you, Kath. That's very helpful. Let's move on then to item 9, if we may, which is a discussion of the CCG's work in relation to recovery following elective recovery following the pandemic. This is being led by Dr. Hilary Byrne, one of our 4 elected healthcare professionals. Hilary, can I hand over to you, please?
Hi, thank you. Sorry, just struggling to turn my mic back on. I think we've got some slides which hopefully somebody's able to share for me. So I was just going to take you through the slides first, if that's okay. You have had the paper, which hopefully everybody's had the opportunity to have a look at, and then this will allow some time for discussion at the end. They're not too many. So can I have the next slide, please? Thank you. So as you'll remember from last year, in the early stages of the pandemic, in wave 1, we were advised by NHS England to postpone non-urgent elective operations for 3 months, and that was from April the 15th onwards. And this was to enable the trust to retrain staff that needed to be retrained to work in different areas, to provide additional capacity to look after COVID-19 positive patients, and to enable space to be freed up in theatres and other areas to be able to admit more patients when that was necessary. And again, in wave 2, there was a further direction that non-urgent elective operations should be paused for a further month. This obviously had a significant impact on our acute trusts, and in between these times, even when the numbers of COVID positive patients in the acute trusts fell, there was still an ongoing impact, and that was really because of a number of factors, which included that wards which were designated for COVID positive patients couldn't be obviously used for elective patients at the same time. Staff were zoned to work with COVID positive patients or not in order to minimise the infection risks. Patients coming in were all tested pre-admission. Some of the staff were still shielding during the waves and in between the waves, and the enhanced social distancing and infection control measures that were put in place in order to minimise the spread of infection, that had an impact on the capacity that was available within outpatient departments, departments that provided procedures, and obviously operations as well. Have the next slide, please. There were some services that were particularly affected on top of that, and they were things like the walk-in service for chest x-rays, steroid guided joint injections. There was national guidance about pausing this because of the infection control risks, and they thought that people may be disadvantaged in terms of their susceptibility to COVID should they contract it. And there was a big impact on things like endoscopies because of the guidance that around aerosol generating procedures and the guidance that came from the Centre and from British Gastroenterology around these types of procedures. People were prioritised in terms of clinical need. So some services where there were patients of varying urgency of need prioritised the patients who were at the most significant, most immediate risk. So for example, vascular surgery. And as a result of all of this, there was obviously an increase in delays to patients coming through the system. So the waiting list increased to 97,000 as of May, and there were a significant number of additional patients waiting longer than 52 weeks as a result of all of this. Next slide, please. So in order to coordinate and organise the recovery efforts, the CCG and partners across the system have been aligning their efforts to make the most of the capacity that we have, essentially, and to ensure the patients with the greatest clinical need get their treatment first, and to minimise the extent to which patients are disadvantaged by where they may live, and to provide better equity for patients. So an elective care recovery cell has been set up, and that's been meeting weekly. There's more detail about that in the paper that you've got, but some of the things that we've been looking at are things like mutual aid, so that's how the trusts support each other. Looking at the best practice as a system, so looking at pathway changes together rather than having differences between trusts in order to maximise capacity and also minimise risk of infection. And also coordinating the approach to bringing in extra capacity. So rather than this being done in a piecemeal fashion, it's been done as a coordinated approach across the system. And also looking at where investment goes in order to try to prioritise that according to where the need is greatest, but also where the potential impact for patients will be the greatest. Next slide, please. So obviously we have a lot of patients on the waiting list that we need to look after. There has been representation from all the acutes and the CCG at a waiting list harm subcommittee. So that's part of the elective recovery cell. And that's been looking at patients waiting, not just in terms of time that they've been waiting, but also with the types of conditions that they're waiting with as well, because some patients will clearly be at a higher risk depending on what the medical issue is for which they're waiting. There was guidance from the centre, requirement from the centre in November that all trusts had to review their patients on the waiting list for surgery and had to code them according to a priority. And there was guidance from national bodies about how this was expected to be done. And there is further requirement for them to prioritise the diagnostic waiting list by the end of July 2021. So, as I mentioned before, there's a number of patients who've been waiting over 52 weeks, waiting for first outpatient appointments as well. There isn't currently a national requirement to review these patients, but we've been looking across the system at what the options would be in order to support those patients and to review them whilst they're waiting. Next slide, please. This just gives you some charts really that give an indication of where things are at the moment. So I hope you can read it. The print's a little bit small. The top left is about elective day cases, and these are regular day case attenders, so people coming for things like day attendances for chemotherapy, that type of thing. And then you've got elective inpatient, non-elective inpatient, and then outpatients at the bottom, which hopefully you can see, and that's split by the 3 hospitals. Next slide, please. So where do we go next with this? So transformation is going to be accelerated through an elective recovery and transformation board. Again, there's more details in the paper around that. We've been encouraging the use of advice and guidance and virtual consultation. So advice and guidance is where GPs can not necessarily refer a patient, but they can write and ask for advice from a consultant, and there's a very rapid turnaround to that within usually a few days, and that may enable the patient to therefore be managed without a referral being needed. this is increasing, but we think there's scope to increase this further. There will need to be some clinical pathway changes, and we're looking at things like what testing is done before referrals are made, yeah, and the system's looking to make sure that its response meets the elective recovery fund criteria. So there's strong focus on health inequalities, looking at outpatient services and how they're transformed and work differently in the future, and tackling the longest waits, and also supporting our staff who have obviously worked very hard through the pandemic and now have this very significant issue to help us deal with. Next slide, please. I think actually that is the last slide. Yes, thank you.
Thank you, Hilary, very much. Your covering note in the second paragraph of the background section referred to the efforts of departments who redouble their efforts to provide timely advice and guidance, in particular through the electronic referral system. Is there anything more you'd like to say about that?
No, it's something that has increased significantly over the time of the pandemic. So as I mentioned, it does enable the GPs, others to get very timely advice, and hopefully in those situations where a referral is being considered but may not be absolutely necessary, it enables a different response. So obviously then not adding to the waiting list is obviously a key priority for us. I don't know, Mark, if you want to say anything more about that.
Yes, Mark, I think it's going to be a focus of us to try to maximise the use of that where it's clinically appropriate. So prior to the pandemic, we had only a very small handful of pathways where it was agreed that was the best route. So, for example, actinic keratosis, which is a kind of skin growth, and really, I think if we are going to use it a lot more, then we need to agree with the hospital consultants which sort of conditions are the best for us to actually use that route in the first place, rather than taking a guess from the primary care perspective. Thanks.
Tracy, you have a hand up.
Yeah, just a question in respect of the harm reviews. So really just wondering a little bit more about those and how that process happens, and how that kind of decision is made, and then some of the kind of outcomes of that people, I guess, are having their elective surgery, if that's the case. Before that, just more information really, Hilary, if you could just share, that would be much appreciated.
Yeah, so the trusts were asked to review all the patients. Are you talking about the surgical waits? Yeah, so they were asked to review and to attribute a level of kind of risk to their surgical wait. So they've been trying to prioritise those really based. In the past, it would have been done on time waiting, whereas they've been looking at factoring harm and reducing harm, and looking at the particular conditions that people are waiting with, and trying to prioritise those people, and also prioritise certain groups of people, and working with the provision that's been available in the private sector in order to make sure that those considered to be at the higher risk or in need of surgery in a shorter timescale we could get those in and get those done first. Don't know if you want to add to that, Mark, at all.
Yes, that's right, Louise. So there is a national scoring system. So this has really helped with us in terms of getting consistent sort of rankings of the patients across the STP. So it ranks from a sort of 1 to 5. So like a P1A is within 24 hours, a P1B is within 72 hours, P2 within 1 month, and so forth until P5, which is the least urgent. And so obviously, so at the moment, very much the focus of the system is to try to get as many P1As, P1Bs, and P2s done as soon as possible. And that's what we're looking at the moment. So it does mean that we're not necessarily taking from the front of the card deck, as it were, in terms of the patients. But if we do that consistently across Norfolk and Waveney, and there is a group that meets to coordinate the efforts, then I think we'll be able to treat everyone fairly.
Are there other questions from members of the governing body, please? Hilary and Mark, do you feel able to answer the question that Joe Russ raised at the beginning in relation to King's Lynn, or would you prefer to reply to that after the meeting?
Mark, I can answer it now, and then if there's
Okay.
if Joe requires any further information, very happy to follow up on that. So, yeah. So in terms of the Iraq blank issue, obviously, the significant impact of that was in mid-March, as you know, and we, as it happened, had we had daily system calls to discuss the issue. So this enabled us to do a few things, such as to transfer patients between hospitals, formerly via the critical care network. So the Norfolk and Norwich did take some patients from the Queen Elizabeth Hospital, and essentially we reached a situation where the critical care unit was not completely shut. They still had capacity for 8 beds, so there was still some activity going. In terms of the second part of Joe's question, in terms of what effect it had on the numbers, it's also very hard to be entirely scientific, but generally speaking, between January and March, the Queen Elizabeth was seeing about between 350 to 500 day cases per week, and between about 10 and 30 inpatient cases a week. In the latter half of March, when the issues were most pressing, they did see over 500 cases per week in terms of the day cases, and over 30 per week in terms of the not in terms of the elective inpatient cases. So, the numbers didn't show a dip, but obviously there would have been significant operational effort put in the system in order to maintain the numbers that we saw.
Thanks, Mark, very much. Clear as a place, you have your hand up. Can we just hear your question to see whether it's one we can answer now or whether we defer to the end of the meeting or after the meeting? Thank you.
Thank you very much. It's just more of a clarification on page 52 of the agenda. It's just really to understand the paragraph where you're discussing the cases, which I guess are Norfolk wide, such as elective inpatient cases, 16,250 fewer than the planned 85,788. Could you just explain what that means, please?
Thank you. Mark, is that something we're able to answer now?
Yeah, so certainly. So we basically set some indicative percentages of what our activity should be by the end of the year, and so we had planned to do about 82,000 by the end of the year, and we were short of that by about 16,000. This doesn't include the activity which we also additionally sent to the independent sector, so that will have made up a significant part of the backlog in terms of that, in terms of eating into it. But yeah, in terms of the acute capacity, I would say certainly the elective inpatients and day cases and the outpatient first were the 2 areas that were affected the most heavily.
Thank you. Arden, you have your hand up.
Thank you. My question was around the diagnostic waiting list, recognising that is an immense challenge for the system, and you'll be prioritising people by July 21. I was wondering what resources you felt were needed to really enable us to have a good system response to that huge waiting list, and what tool that you will be utilising in order for us to prioritise people across for urgency. And then secondly, well, that was the main thrust of my question, actually, but the other one was around combined waiting lists, and was there any plans to do combined waiting lists across the acutes in certain areas other than what you've mentioned?
And shall I take that?
Yeah, thanks, Mark. I mean, I was just going to say there is a whole programme of work around diagnostics and waiting lists, and a number of initiatives that are coming up about increasing diagnostic capacity going forward, especially in the context of the critical role diagnostic plays in pathways and in being able to refer people to the right place or not refer people. So there is a whole programme of work, and I was on a meeting with NHS England this morning about this very issue. But Mark will give you the specific details about Norfolk and Waveney.
Yeah, thank you, Arden. Thank you, Hilary. So yes, at the moment we are sort of seeking additional funding through 2 routes. So one's the accelerated diagnostic program, and the other is the community diagnostic hub program as well. So so we have sort of sent those submissions in, which were due at the end of last week, and hopefully that will enable us to have additional capacity, you know, at our acute hospital to do that. We have also included provision in that for other things such as phlebotomy as well. So we'll await the outcome of that. And in terms of the single PTL work, there's now a sort of a project board or project group that has been set up to oversee the delivery of that. So that should significantly strengthen the leadership and the clinical input into that program. It's very much not just an IT issue, it's also, you know, the way in which clinicians work together issue as well. And I think having that group will definitely help to move that forward. As the paper said, our first pilot area is going to be upper GI endoscopy, which aren't 2-week waits as well. And one of the particular reasons why we've chosen that program is that the recovery trajectory at the 3 hospitals has significantly varied over the course of a pandemic, and so there's an opportunity there to potentially look at sort of sharing some of that resource. Clearly, there's going to be things that we would have to work out, such as, you know, for example, if you're a patient that lives in Lowestoft, then your next available endoscopy is in Norfolk and Norwich. Do the results then go back to the local consultant, or will the patient be followed up in the Norfolk and Norwich? And those are the pathway things which just require a bit of effort for us to, you know, to work through, but they'll definitely be worked through.
Thank you both.
Rob.
Very comprehensive.
Rob.
Yes, thank you, Chair. It was a comment on the bar charts in Hilary's presentation. The most striking feature when I looked at those was how the activity levels you start to see the recovery in April, compared with obviously the very difficult days in February and March. So I was encouraged to see the activity levels coming back across the board as soon as the situation started to improve.
Yes, thank you.
Thank you.
Chair Russ, you have your hand up again. Can I just check whether you'd like to ask another question now, and then we can decide whether we can answer it or defer it to the end?
Yes, I'd like to put it to you now, but appreciate that you might choose to answer it later. I don't want to be a doubting Thomas when Dr. Lim has said that there was no, numbers didn't show a dip because of the closure or partial closure of CCU. So obviously I will congratulate the amazing hard-working NHS staff that made that possible and thank them for their efforts. What I would ask is, what would you say to the catchment area for the Queen Elizabeth Hospital, some 1,500 kilometres squared, serving a population of 331,000 31,000 people, when you said in your slide you're prioritising investments to where there is greatest need and greatest potential for impact, and you've prioritised that investment in the James Paget theatres, when the people in our area would say, and I fully appreciate, one trust shouldn't be in competition with another trust for funding, but our hospital hasn't received funding yet for a new hospital. Not only has the James Paget received that, but the CCG, which does have control over this investment, has given more money to the James Paget and not to the QE. So what would you say to the catchment area of the Queen Elizabeth Hospital when making those decisions?
Thank you, Jay. Well, we've made a note of that question and we will come back to it at the end to see how best to answer it. Right, if there are no other points on elective recovery, let's move on to item 10, please, the clinical threshold policy recommendations. And Mark, this is over to you, please.
Thank you, Chair. So we've got clinical thresholds here today for approval in relation to carpal tunnel and Dupuytren's contracture. So if I may just quickly, I'll take the papers as read. In relation to the carpal tunnel syndrome, I think we've had a situation where I think clinical practice has varied across the patch. So some GPs are referred to the surgeon, and the surgeon's ordered the test, and in other cases the GP's ordered the nerve conduction study and then referred to the surgeon. So this was also identified by some of our general practice members of the CCG as being an area that we needed to sort of standardise practice on. So my clinical advisor colleagues have held a series of meetings with the surgeons and the neurophysiologists at the hospital are the ones who conduct and are clinically responsible nerve conduction studies, and we believe that that policy that we've got is the one that will result in the investigations being best used and the most appropriate patients being referred to hospital for surgery. In relation to the Dupuytren's contracture, so we've had for a while a policy whereby you've got essentially two joints in the finger where you potentially might have it. So one and in the joint that's close to the body of the hand, then there's been a policy that's been in place for some while that it should be contracted to 30 degrees before it's referred. We've done a review of the evidence, and that seems to be supported by the evidence and is also consistent with other CCG's policies. In relation to the part of the finger which is closest to the tip, the evidence does seem to show that if there's any degree of contracture, i.e. bending, then the patient will still potentially benefit from treatment. So we've abolished the 10-degree threshold for that. So GPs won't need to get their protractors out to measure to see whether or not that's 10 degrees or not. And we've been supported by that, I should say, by a public health review in relation to that. So I would recommend the report and the policies to governing body for approval. Thank you.
Thank you, Mark, very much. Are there questions for Mark, please, on these recommendations? If not, can I ask if you're happy to ratify them, please? See lots of nods around the table. Thank you very much indeed. That's very helpful. So we're on to item 11 now, the recommendations from the Drugs and Therapeutic Committee. This is being led by Michael Dennis, head of our medicines optimization. Michael, can I hand over to you, please?
Yep, thank you, Chair. So I've got two papers which are the commissioning recommendations of our Area Prescribing Committee, Norfolk and Waveney Therapeutic Advisory Group, also known as TAG, for ratification. I'll take the papers as read. Just a couple of things to highlight on the April paper. Insulin Aspart, Fiasp, and brolucizumab. TAG is making these available for the small number of patients who may benefit from these, as opposed to the originator medicines that they effectively extend the patent of, because there are more cost-effective products coming out in the near future. So next month, in the case of a biosimilar insulin of Novorapid, and next year in the case of a biosimilar Lucentis, which will save the health economy a considerable amount of money. But we recognise that there are a small number of patients who might find insulin aspart useful because it's very slightly faster acting, and brolucizumab might be beneficial in some patients who need fewer appointments, fewer attendances for their injections for wet AMD. So papers are here for ratification, if that's possible. Happy to take questions. Thank you, Chair.
Thank you, Michael. Questions for Michael, please. Again, are we happy to ratify those two sets of recommendations then, please? Lots of nods. Michael, thank you very much.
Thank you.
We are actually 5 minutes ahead of time. I'm going to suggest we just take a 5-minute comfort break, if that's all right. Just give ourselves a chance to stretch our legs, and back on screen again at 3:05, please. Okay, it's 3:05. Shall we move to item 12, please? And Doris Jameson, lay member and Freedom to Speak Up Guardian, is going to lead this item, a report on the work of the Guardian through 2020 and 2021.
Thank you very much, Chair. I take the report as read. I started post partway through the year, so the figures are really for half a year results. And it is good to see that, you know, a number of staff have felt that they were able to approach me either for just a casual conversation to see whether it was something that needed to go further. And obviously a number of people have taken the cases a bit further. I'm happy to take any questions.
Thank you, Doris, very much. Questions for Doris, please? Melanie.
Thank you, Chair. Doris, thank you for bringing this report to our attention and also for taking on the important role of Freedom to Speak Up Guardian. I think, you know, the more we can do to make the culture within the CCG and indeed the wider health and care system one where staff at every level in every role feel they can contribute, just give suggestions, ideas, and also speak up when things are not going well, is really, really important. And I wondered if you had any thoughts on whether we needed to, whether we could potentially train up other members of staff to work alongside you, with you at all levels. I'm aware of some organisations that do this, where they have a little network of champions throughout the organisation to try and just embed and extend that practice and culture.
Thanks, Melanie. I think the answer is yes, and probably pandemic has put a hold on, I'm very conscious of staff time and resources and bandwidth. I think especially for where general practice are using the CCG service, it's probably doubly important for somebody based locally rather than a figure that they have no idea who. I mean, obviously they've seen my profile and they know who I am. So I very much, kind of on my radar. Hopefully, as things return to the new normal, there's going to be more opportunities to get more colleagues involved. I think part of the issue is also about training. Training is a bit sort of haphazard for those who are not in the Guardian role, but there is training available locally that we can try and tap into. But a lot of it is focus around the acute trusts, and the CCG type environment and the GP environment is slightly different from an acute trust, but I'm mindful of that.
Rob.
Yeah, thank you, Chair, and thanks, Doris, for a very informative and helpful report. As Melanie said, this is an important area of work for us, and I was very pleased to read the report. I had a question on the staff survey and wondered what the response rate was to that survey, and a similar question to Melanie in a sense. Is there anything more that you think we should be doing as a governing body to promote the culture around this particular area?
I think there's a number of things. I think is the rollout of the training that has been put in place by the National Guardian's Office. Certainly the first module was very easy to use, and I think there is plans to make that mandatory for all staff. At the moment, the take-up rate is 68% of the staff have attended that first level of training. There's also training now being rolled out for managers to try and help managers to make it speak up easier for the people they line manage. And obviously, as governing body members, we should be all doing those training as senior leaders within the organisation, and actually encourage everybody. It's about actually listening to what people are saying to us, and it's more difficult in a sort of virtual environment because we haven't got those, water cooler conversations or making the coffee conversations. But there's always more we can do, and I think being open-minded about it, and and I think that helps, and also the work that Caitlin's doing with organisational development, I think will help as well in terms of, because all these things are linked in terms of equality, diversity, inclusion, and having an open culture and listening, truly listening to what people are saying to us.
Hilary.
Sorry, I've got a very awkward mouse that's misbehaving. I was just going to mention, Jo, actually, because I took on the responsibility as a wellbeing guardian. I think there is some linkage to be made really between that approach and your role, and if there are key themes and learning that's coming out of the work that you're doing, I think it'd be really helpful to link that across really to the work that Jo's doing and the way we're looking to set up really from the wellbeing kind of guardian perspective as well.
No, I totally agree. And obviously the CCG has also got an EDI group working now, and all these things help to feed in, you know, to encourage a more open discussion for all staff members.
Melanie, I do apologise. You were probably wanting to respond to Rob's question, weren't you?
It's fine. I'm very happy to just come in and also just follow on from what Hilary's just said actually too. I mean, I think in some ways working virtually has made some things easier to engage staff. We've been able to meet with all staff across our huge county plus Waveney in, you know, every single week with very high numbers because we can do that virtually. So some things have been easier, but we continue to develop more and more and just pile on as many different ways as possible for staff to feel involved, included, have opportunities to say what they want to say and for us to listen. And I mean, I think in terms of your specific question, Rob, we have this staff involvement group which I chair every month, which is very well attended. Other directors come along to support as well. Jossie is also going to co-lead the health and wellbeing group with Hilary as a kind of offshoot of that as well. So we put a focus on that. We're we did a couple this week and have a few further next week, have workshops for staff around values and resetting our values. And I think what's really key at the moment is having as much visibility as possible. So although we don't have the water cooler moments, we can virtually create them with a virtual coffee queue kind of session. And I mean, I would love for governing body members, for the lay members to join the coffee queue, or to come along and just be visible and be present. You know, you're part of the organisation, more listening, and just to reflect back to us, because you know there are you know, obviously challenges working like this as well. But we've just done 2 staff surveys, not the Freedom to Speak Up one, but we've just done 2 further surveys. One was about health and wellbeing of our staff, and one was about how they've found working virtually and what they would like for the future. And the response rate has been incredible. It's been like over 85% for both surveys. So staff are engaged, these things are important to them, and I really want to just build and capitalise on that. So I'll be very grateful for your help and creative ideas as well.
Thank you, Melanie. I'm sure we'd like to take you up on that, and that's been an interesting discussion. Before we move on, can we just make a note of Jo Rust's question? Jo, you have your hand up. Can you just let us know what the question is and we'll make a note of it?
Yes, thank you. It was in relation to the 10 GP surgeries that has signed up to work with Doris on the Freedom to Speak Up Guardian. I understand there are lots and lots more GP surgeries that haven't signed up, and I totally understand that the Freedom to Speak Up Guardian, there is a focus on acute trusts and CCGs, but what more work is being done to encourage these GP practices to sign up? Because in my experience, many of the staff that work there, who work in a private sector environment where trade unions aren't recognised, are often those most in need of that facility. Thank you.
Thanks, Jo. We'll come back to that question at the end and let you know how best to answer it. Okay, let's move on, please, to item 13, which is the end of year position for our 2021 financial year. Over to you, John Ingham, please, Chief Finance Officer.
Thank you, Chair. So it's just a brief report today, and as you say, it's to note the final financial position for 2020-21. So we're still currently going through the audit process, so it's not completely finalised and signed off yet. But I'm pleased to say there's nothing material or significant coming through that process so far. So as things stand, we're reporting a small surplus of £600,000 against a total spend of £1.9 billion in the last financial year. A couple of quick points to note. One is that is an improvement on the plan that the governing body signed off back in November, which was a plan for the second half of the year of a deficit of just under £5 million. And whilst it's a positive financial result that we actually achieved a small surplus, a fair chunk of the improvement was because of the pandemic, meaning that we couldn't get through elective work. And so it comes back to the item that we had earlier that Hilary and Mark were talking to. One final point I would make, just to point out in section 5 of the report, it's worth noting that we had over £200 million worth of non-recurrent funding into the system through the CCG in the financial year that's just finished. And this reflects the financial framework that was put in place specifically for the pandemic period, which was effectively intended to make sure that the costs of the NHS were covered, so that financial considerations didn't get in the way of people responding appropriately to the pandemic. So I think it's worth holding that figure in mind, that there was a very large sum of money put into the system to cover the costs of principally the providers in the system, but also some elements within the CCG. As and when we return to a normal financial environment, the expectation would be that level of support maybe wouldn't be there going forwards. Still don't know what the financial framework would look like, but I think it's worth noting that we know that there are certainly further challenges ahead. But I'll pause there and happy to take any questions on the financial position for the last financial year.
Many thanks, John. Can I throw it open to questions, please, from governing body members? No questions? In that case, can I just check we're all happy to receive that? Oh, Chair, all happy to receive that report, please? Thank you very much indeed. Can we move on to item 15 then, please? Sorry, so item 14, the financial plan for the first half of the financial year. Again, this is you, John. You're on mute, I think, John.
Sorry, had to happen, didn't it? So yeah, we've done the look back. So this is the look forward as such for the first 6 months of the year. I'll recognise we're almost a third of the way through that so far. So the paper in front of us today is to confirm the financial plan that we've submitted for the first half of the year. That plan had to be submitted a few weeks ago, so it was done so on the basis of Chair's approval, following consultation with Hein as Chair of Finance Committee, as was noted at the start of the meeting. The plan shows break-even position for the CCG for the first 6 months of the year and a break-even balanced financial position for the system as a whole. That's not without its challenges, it's not without its risks. And in particular, I think risks associated with the elective recovery, again, that we've talked about before, and the national framework that's in place, whereby the more elective recovery that we can do, the more elective work we can do, the more funding that will attract to the system. In the same principle, as I said before, that money shouldn't get in the way of elective recovery. So there's some assumptions within the plan about a certain level of activity, and therefore some funding that will come into the system on the back of that activity. So that's probably the main degree of risk in the plan for the system as it stands. I think it's also worth noting that we are still in this interim financial regime, hence it being a plan for just 6 months of the year. And as I said before, we don't yet know what the financial framework or the guidance or the funding envelopes will be for the second 6 months of the year. But as and when we hear more, we'll obviously bring that back to the governing body. But as I say, this report again is for noting today, given that it was approved offline.
Thank you, John. Throw it open to questions again, please. No questions? In that case, we will note that report. Thank you very much, John.
Thank you.
Let's move on then to item 15, the Governing Body Assurance Framework. And Karen, can I hand over to you as Head of Governance, please?
Thank you, Chair. The Governing Body Assurance Framework is here today for the Governing Body's review and comment. We have been through this framework internally, both for our senior management team and the executive management team. There have been a few changes since the last iteration of the assurance framework, and we've summarised those in the paper, so hopefully you've had an opportunity to review those. There is one risk that we would like to move from the governing body assurance framework now, because the risk has been reduced to a level where we think that it no longer needs to be on the governing body assurance framework, and that is risk number 5. Happy to take any questions on the framework itself, and in addition, most of the risk owners are here today and can give you any detail on any specific risks. Thank you, Chair.
Thank you, Karen. Questions of Karen, please. John.
Just for clarity, Karen, I think it's risk number 3, isn't it? We're looking to remove. It was about the CHC recovery.
Apologies, Chair. It is about the CHC recovery, if I've got my numbers incorrect.
Yes, that's right. Yes, because the 5 is the CQC special measures one.
Thank you.
Hein.
Thanks, Chair. I had a question on risk 14. So on page 110, the visual, the matrix suggests it's the top right, and the risk score in the underlying register is 20. So I think it needs to be one of the two. But more importantly, the risk refers to the NHS constitutional commitment, and having heard Mark and Hilary talk about the prioritization and the elective recovery baseline, would that not be, given the pandemic, the more relevant marker for this risk at the moment? It's an open question, but that's the one I have.
Thank you, Hein. Karen?
I'll pass to Mark Lim, if I can, who's the risk owner for that line.
Thank you, Hein. We have altered the risk, the terms of the tolerated risk leveling to 4 by 3. 4 because I think, as you can see from the presentation, we're likely to have some significant work to do in order to recover the elective position. But the reason I've lowered the tolerated risk rating to, in terms of consequence, to 3 is because we do undertake the prioritization processes which we've described, was the ones already done for the waiting lists for surgery, for diagnostics, and also potentially the outpatient referrals as well. Then we may still have patients who waited longer than they used to, but at least we'll have known what priority they should be seen in. And so I felt that that 3 was probably where we should aim for in terms of the consequence, i.e. we're still waiting longer, but at least we know who's in the greatest need.
Okay. Yeah, thank you.
Rob, then Doris, please.
Yeah, thank you, Chair. It's just on a comment on risk 3, Karen, and the removal of continuing healthcare from the register. Reading the commentary about the controls that are in place, that implies to me that there's still more work that needs to be done. So I wanted to suggest that we ask the executive management team just to have another look at that, to be satisfied that we are in a position that we can close that, rather than closing it prematurely.
Thank you, Rob. I don't know if Kath just wants to chip in there as the risk owner.
Thank you. So I think what I wanted to point out is that the risk relates to the recovery programme, which needed to have been achieved by the 31st of March, and we did achieve the recovery. So we assessed 100% of the backlog of cases that were as a result of the hospital discharge programme approach. So what I would suggest is that we close this action, because the risk has the risk deadline has been passed and we achieved that, but maybe look at another risk in recognition of the wider risk associated with CHC and maintaining the programme as needed, and also considering any financial risks associated with that.
Yeah, Chair, I think that would be very helpful, and I was aware that we'd made good progress in clearing the backlog to the 31st of March. So I think Kath's suggestion there is a good one. Thank you.
Thank you.
Thank you, Kath and Rob. Doris.
Thank you, Chair. Just couple of general comments. One was in relation to, because the documents being shared in public, there's a few sort of abbreviations that even I scratch my head to go, what's that? So can I have a plea? Can we have a bit of a longhand, please? And can we have a bit of consistency in terms of dating between the US system and the UK system? We are still in the UK. Although weather-wise, we might prefer to be in the US. It was a question for the executive to consider in relation to the primary care risk. Is at the moment it's very much about COVID, but I just wonder whether there is a risk as we return more to normal, because different practices having slightly different digital maturity, they're using different systems, expectations in the population, and are we in danger of creating health inequalities because we haven't got a consistent approach across Norfolk and Waveney? I just would like the executive just to have to think about whether that's a narrative that we need to add.
Thank you, Doris. Mark, wanted to come in?
Thank you, Chair. Yes, just thank you, Doris, for the question and the suggestion. I think that's absolutely right. We are very much aware that the face of primary care is changing, not least through the pandemic, but also what will come to follow. So absolutely, I expect over the next 6 to 12 months that we will see substantial change in the reporting in this area. But thank you for flagging.
So we're happy to note the report, just subject to those 2 points, that the executive team might look again at the CHC wider risk and the primary care point that Doris has just raised. Thank you very much indeed. Joe, do you have another question we'd like to?
Yes, I mean, because obviously the RAC planks are issued, noted on the Board Assurance Framework 12, and it's dated September 2020. When would there be an update on that risk? Because I know that it said this may lead to risking the safety to patients, visitors and staff, and I would assert that having to move clinical care patients did present a risk to them, so there was no may about it. So I wonder when this risk would be updated.
Thank you, we'll note that. Right, can we move on to committee reports, please? First one's from the Quality and Performance Committee. Kathy Branson, our registered nurse, can I hand over to you, please?
Thank you, Chair. The report presented covers the meetings for March and May. We stood the April meeting down because of capacity issues caused by the COVID pandemic and vaccination campaign. I'll take the report as read and ask whether the governing body has any questions, please.
Any questions about the Quality and Performance Committee, please? No, then we'll note that report. Thank you very much, Kathy.
Thank you.
Moving on to Finance, Hein van den Wildenberg, lay member for Finance. It's a verbal report, I think, today, Hein.
Yes, Chair. The meeting was exactly a week ago, so there was no time to include a paper in the pack, but I'll go quickly through some of the items discussed. We discussed the first half of the current financial year plan. John has covered that just now in the meeting, so I won't add anything to that. We had our first committee development session focusing on recurrent and non-recurrent funding, and as you heard John refer to, we had last year quite a bit of non-recurrent funding, and that's no guarantee for this year, so that was an important topic and also a good precursor for a discussion on how our financial performance moved between the 1920 financial year into last year and how it has informed the current financial plan for the first half year. We also discussed a summary report on acute activity with both finance and clinical input, learning about key developments there. And lastly, we reviewed the finance risk register. Happy to take any questions.
Thank you, Hein. Are there any questions for Hein? Otherwise, we'll note the verbal report and look forward to seeing the a formal note in due course. Let's move to the Primary Care Commissioning Committee. Doris, this is yours.
I take the report as read. It covers the 2 meetings in April and May. Happy to take questions.
Thank you. Any questions for Doris on the Primary Care Commissioning Committee report? If not, we'll note that and move on to the Audit Committee. And Rob, as lay member for Financial Management and Audit, can I hand over to you?
Yes, thank you, Chair. Again, I'm very happy to take any questions on the report itself.
Seeing none, we will note that one and then move on to the report from the Clinical Executive of the CCG, and that's you, Mark.
Thank you, Chair. I'll take the report as read. I'll just very briefly summarise the work over last year. So as a result of the COVID pandemic, we've stood up a meeting to essentially engage with all the lead clinicians in the CCG as quickly as possible, so on a weekly basis initially and now bi-weekly. Obviously, over the course of the year, the focus of the group has changed from looking at sort of admission pathways of patients with COVID to go to hospital to moving on from that to looking at areas such as long COVID services, oximetry for patients with COVID at home, and gradually over the course of the year, as you can see, we're now moving back to some of our longer term plan objectives, such as helping to reduce cardiovascular risk factors and working on inequalities. So just before I finish, I'd just quickly like to acknowledge the support that our public health colleagues have provided to that particular meeting, because it's enabled us to make clinical decisions in the context of what's happening with the pandemic. Thank you.
Thanks, Mark. I thought it was a really useful note, and you asked the question there whether we'd like to receive it on a bi-monthly basis. Can I throw that question open and also ask if there are any other questions on Mark's note? Is the general feeling we'd like to see that on a bi-monthly basis? Yep, lots of enthusiasm for that. Thank you, Mark, if we can see that again. Right, that concludes the committee report. So we're on to item 21, which is questions from the public. Karen, can I ask you just to take us through questions from the public?
Thank you, Chair. Yes, we haven't had any questions via the email inbox during the meeting. We did receive 2 questions ahead of the meeting. I'll just share them on the screen now. The governing body have had an opportunity to review these this morning, because they came in just yesterday and on Friday, but they're up on the screen now for the benefit of the public. They will be put on our website later as well for people to read at their leisure. Just like to hand to Mark Burgess, who can talk you through these 2 questions. Thank you.
Thank you, Chair. Thank you, Karen. So acknowledging there's lots of words on the slides here, as Karen said, they will be available afterwards, but I will look to summarise just for those here today. So the first question was around the contractual position relating to interpreting and translation contract, and flagging, I think, valid concerns about the current position, particularly with relation to access. So if we could go to the next slide, please, and I'll just pull a couple of key points from this. And as I say, we will also write to individually to those people that have asked the question with the detail and answer to their questions. But both this service is commissioned by NHS England and NHS Improvement. We have linked with them in this response. And both they and we as a CCG acknowledge it's been difficult with relatively poor access to British Sign Language interpreters for some during the pandemic. And so what are we doing about this? So just a couple of things we'd like to flag and noted here. There is an additional service, an enhanced deaf support service, which we hope will be commencing next month to offer support to individuals in the deaf community unable to access existing services in making primary care appointments, and that I think is due to last, I think, till March 22. And in addition to that, perhaps the even more important work, the longer term, in June this year, work will be starting to have a provider in place covering dentists, pharmacists, GPs and opticians from November this year, and that should be covering the majority of the east of England, Norfolk and Waveney as well. And that's been very much informed by the local engagement events that were held last year. Obviously the pandemic has interrupted some of this, but I hope that provides some reassurance. Really important work that we hope will push on at pace. The next question, please, next slide. We've also had a question around the Norwich, the walk-in centre in Norwich, and about its contractual status, and a question about other practices, other areas of Norfolk where this is in place. So if we move to the next slide, we've just summarised this quite concisely. So there are a number of contracts in place, and those areas that do have that in place are listed here, and their expiry of their contracts. Also including the walk-in centre that was specifically referred to in the original question. So I hope that's helpful, and happy to take any specific questions on that.
Thank you very much, Mark. Anyone like to add anything to what Mark has said? Karen, what are the other questions, please?
So we haven't received any other questions via email, but it's now open to any other members of the public if they'd like to ask anything further. I think, Jen.
Okay. Joe Russ, can I go to you first?
Yes, I'm sure that you're really pleased I've attended today. Your risk register makes mention of NHSE guidelines for best buy hospitals and a Ratzer scale used to assess the failure. I've done a search, albeit a quick one, on NHSE guidelines for best buy hospitals, and I can't see them. I would very much, as a member of the public who has to use the Queen Elizabeth Hospital, like to have this NHSE guidelines for best buy hospital shared with me, please, or a link sent so that I can read it, because I think if you're referring to documents that you're using when, you know, dealing with our Queen Elizabeth Hospital and other hospitals in the area, I think the public should know what they contain, please.
Thank you. Make a note of that and certainly do what we can to provide what you're requesting. Are there any other questions from members of the public? In that case, we'll move on to any other business, please. Does anyone have any items of other business? John.
Sorry, Chair, I was just going to offer an answer to one of the questions that was raised earlier in the meeting, if that's okay, by Joe Rust. In terms of the elective recovery discussion and the issue about capital investment to support elective recovery, I believe the question was around potential lack of investment at the Queen Elizabeth Hospital. So just wanted to clarify the position on that. So the position with that is that we have limited capital monies within the system, but it's governed by a system strategic capital board, which I chair with my system hat on, and has representations from all the providers. It is not a CCG forum at all. And that group made available £3.5 million to support additional investments to support elective recovery this year. And it asked the elective recovery cell, the system elective recovery cell, to identify the key priorities for that. And they came up with a list of 3 things, which was considered and discussed by the Strategic Capital Board a couple of weeks ago. The key things on that list: the first priority was theatres at the James Paget. The second priority was a mobile endoscopy unit at the Queen Elizabeth Hospital, and both of those top 2 priorities were agreed. So £1.5 million for theatre at the Paget, £2 million for mobile endoscopy unit at the Queen Elizabeth Hospital. And actually that development in itself, by pulling endoscopy together, freeing up some theatre time, some day case time in other parts of the hospital, would release around 3,700 elective procedures, day cases per year, and 5,500 outpatient attendances. So it's just to give a bit of clarity around the fact that there is additional investment earmarked for support for elective recovery at the Queen Elizabeth Hospital, and it was very much a system decision to get to that point.
John, that's very helpful. Thank you very much indeed. Any other business, please? In that case, it just falls for me to thank everyone for all the work that's gone into the meeting this afternoon. Thank you to members of the public who've joined us this afternoon. We do appreciate the interest you show in the work of the CCG. And the date of our next meeting is Tuesday, the 27th of July at 1:30, the venue to be announced. Thank you very much indeed.
Thank you very much. Bye-bye.
Bye.
Bye. Bye.